So, dear friends, thank you for having me on this beautiful conference. I'm so excited to be here with you. And today I'm going to speak about a very interesting topic about the therapeutic advances in functional dyspepsia. My name is Radislav Nakov from Medical University of Sofia in Bulgaria. So, dyspepsia is a complex of symptoms referable to the gastroduodenal region of the GI tract and includes epigastric pain or burning, postprandial fullness, or early satiety. As you all know from your experience, dyspepsia is extremely frequent, but unfortunately, it's underdiagnosed in most of the cases. It's interesting that 80% of the functional dyspepsia is functional, so there is no organic reason behind it. And we can divide it into three types. The so-called epigastric pain syndrome, postprandial distress syndrome, or overlap syndrome, according to their own four criteria. In this presentation, I'm not going to focus on the diagnostic criteria of functional dyspepsia and how are we going to differentiate it with the organic reasons for dyspepsia. Rather, I'm going to speak about the therapeutic advances in this functional disorder. The prevalence of the disease is extremely high, as every functional disorder. It's between 10 and 16% in different analyses and epidemiological studies. But there are very big discrepancies between different countries. You can see, for example, 2.2% are reported in Japan, 12.3% are reported in Egypt in a recent international study. So you can see that there are some big differences between countries, maybe due to various reasons. The risk factors are psychological comorbidity, of course, acute gastroenteritis, the female sex, smoking, use of non-steroids, and Helicobacter pylori infection. Unfortunately, the pathophysiology of the disease remains uncompletely understood, but we can underscore some very important parts in the pathophysiology of functional dyspepsia, and this is mainly the disordered communication between the gut and the brain, which leads to motility disturbances, visceral hypersensitivity, and alterations in microbiota, mucosal, and immune function, and of course, the central nervous system processing. This is important because based on this pathophysiology, we try to organize our management and the therapeutic advances. Although treatment is a real challenge for the everyday clinician, especially in gastroenterology and in general medicine, because the disease is chronic and the natural history is one of the fluctuating symptoms. So it's really demanding disease, and we have to do a lot in order to have a better management. Speaking about the management, it's important to be sure that there is no structural cause for the symptoms in every patient that we have under the diagnosed functional dyspepsia. So we have always to rule out organic disease, and we have to try to explain to ourselves the pathophysiology and the natural history of the disorder of the individual patient. The treatment is almost every time directed towards the predominant symptom with a realistic discussion of the limitations of the available therapies to manage expectations. It's very important to explain to the patient what's the disorder and what are the treatment goals. And it's quite important to tell to the patient that his or her symptoms can flare back, so this wouldn't be a surprise for your patient. Lifestyle changes or exercises, which are something like the first advice that we give to our patients with IBS, unfortunately are not working very well here, and we have very little evidence for them. Diet, also on the other hand, compared to the IBS, is not very well understood in functional dyspepsia. There are really few randomized controlled trials, and it's not endorsed by UEG and the European Society of Neurogastroenterology and Motility Guideline, which was published recently. Medical therapy is the mainstay of the treatment, and modest effectiveness and actually of the most of the therapists is a real problem. So actually, our goal is to alter the long-term natural history of functional dyspepsia. So we're going to focus mainly on medical therapy in this presentation. First of all, before showing you what are the therapeutic advances and what are the most common therapies that we use for functional dyspepsia, I want to show you this chart, and it's a very practical and useful for the everyday practice. It's from, I got it from one of the recent papers of Alexander Ford from Leeds University. It's originally a chart from Moya Eddy, one of his articles about functional dyspepsia. So the most important thing here in this chart is that if we have dyspepsia in a patient and he is above 55-year-old with alarm symptoms, we have to do endoscopy with biopsies for Helicobacter pylori. If he is positive for HP, we should start eradication therapy. And if symptoms resolve, we discharge the patient. If the symptoms persist, we can carry on PPI therapy. And of course, if symptoms resolve, we win PPI to lowest possible dose and discharge the patient. And if PPI therapy doesn't work, we carry on with tricyclic antidepressants or prokinetics. If the endoscopy is normal, we go straight to PPI therapy. And depending on what's going on after the PPI therapy, we decide if we have to include TCA or prokinetics. If the patient is below the age of 55 years and has no alarm features, we have to do a non-invasive test for H. pylori. And if it's positive, we go to the used eradication therapy in our country. But if the H. pylori is negative, we start with PPI therapy. If the symptoms persist, we go to tricyclic antidepressants or prokinetics. As simple as it is. But in real life, unfortunately, it's not that easy to treat patients with dyspepsia because the pathophysiology is quite complex. But what you can remember from this chart is that we have to perform endoscopy to patients above 55 years with alarm features, always have to test the patients for H. pylori, and we have three main treatments for functional dyspepsia: eradication therapy for H. pylori positive patients, PPI therapy, and other therapies, let's say. So eradication of H. pylori is something that we very well know, and we have to be aware of the peculiarities of our own country about the clarithromycin resistance and the H. pylori prevalence, something that we know very well for Egypt, for example, because of the good epidemiological studies. In the UEG-SNM guideline from this year, H. pylori positive functional dyspepsia patients are recommended to receive eradication therapy. So this is one of the recommendations from the guideline, and I will come back, carry on to this guideline to show you that it makes really a few definitive statements, and this is one of them. A really big meta-analysis of 17 randomized controlled trials shows that the symptom persistence, the relative risk of symptom persistence after eradication is 0.9, and actually eradication therapy is better for epigastric pain syndrome than in patients with postprandial distress syndrome, and it's cost effective. Acid suppression therapy is something that we know very well. It works also very well in functional dyspepsia patients. Unfortunately, antacids and sucralfate and bismuth are not that useful, and we don't have enough evidences for them. The UEG and TSNM guideline says that PPI therapy is an effective therapy, really effective therapy for FD. And we normally give once a day omeprazole or lansoprazole or ranitidine, but once daily. A meta-analysis of 18 studies reported a relative risk of 0.88 for symptoms persisting with PPIs versus placebo. And there is no big difference in efficacy between histamine 2 receptor antagonist and PPIs into randomized controlled trials. There is one trial showing that PPIs are better in postprandial distress syndrome than in epigastric pain syndrome. When we speak about prokinetics, most of the studies are either about acutiamide, 100 milligrams, or etopride, 50 milligrams, 3 times a day. Prokinetics are more effective than placebo in meta-analysis with relative risk of 0.81. Actually, I can tell you for my personal practice that most of the time I use prokinetics together with PPIs in patients with functional dyspepsia, and the results are really better in terms of symptom relief. But this is not something that I'm showing you as a published result, but as my personal experience with patients with functional dyspepsia. Buspirone and tanduspirone, which are 5-HT1A agonists, lead to fundal relaxation and could be useful in functional dyspepsia. In a crossover trial of 17 patients, these drugs showed that they could relieve the bloating and the postprandial fullness. In a randomized controlled trial of 144 Japanese patients, the response rates after 4 weeks of treatment with tanduspirone was better than those with placebo. So prokinetics, as a summary, have their role in functional dyspepsia treatment, especially in those who are refractory to PPI treatment. One interesting therapeutic advance and interesting prokinetic drug is trimebutin maleate. Trimebutin is not available in every European country, for example. I have personally experience in Bulgaria with it. It has antimuscarinic and mu, kappa, and delta opiate receptor agonist effects, and it's suitable for use in treatments of many functional GI disorders, IBS, functional dyspepsia, even gastroparesis. And in a multicentral randomized controlled trial with more than 200 patients with a leading author from Greece, actually trimebutin 2 times a day was better than placebo for a 4-week treatment. It significantly reduced the Glasgow dyspepsia severity score and led to significant symptom relief in the group of TM patients. Trimebutin monotherapy appears to be an effective and safe approach to treating functional dyspepsia, and further confirmation, of course, is needed to this group of patients. Central modulators, here are also the antidepressants, are quite interesting. There is no benefit for SSRIs or SNRIs, but tricyclic antidepressants are really useful in some patients, but we have to be careful for their adverse events. They're more effective than placebo with a relative risk of 0.74. And they're quite useful at a starting dosage of 25 milligrams a day at night before going to sleep, which is titrated up to 50, 75, 100 milligrams per patient a day, depending on the response of the patients. I personally have experience with giving amitriptyline in patients with functional dyspepsia, and it's quite effective because it has its logical effect on gut-brain interaction. Some studies say that it's better for patients with epigastric pain syndrome than in patients with postprandial distress syndrome. Mirtazapine is another central neuromodulator, which is better than placebo and has significant improvement in early satiety and quality in life. Some other therapies that are discussed in randomized controlled trials of functional dyspepsia patients are the well-known antibiotic rifaximin, which we know from IBS therapy. Unfortunately, it's not that useful in functional dyspepsia. But in this one controlled trial, it showed significant increase in rates of relief of global symptoms and postprandial fullness. Some psychological therapies like gut hypnotherapy or behavioral therapy, there are so low evidence for them, so we cannot discuss them further, and they are interesting to be discussed in the future as a potential therapies for functional dyspepsia. Phytotherapies like Iberogast, caraway oil, almond oil, and the Japanese phytotherapy Riconchito, they have some studies with good results, but the evidence is little, so we cannot make any final statements. Another alternative therapy is the Electro Acupuncture, of course, from a study from China, showing that patients who has been treated for 4 weeks, 20 sessions, they have benefit over the control group. But still, this is something that is very unknown for the West world, and we are not sure how it's going to work on our patients. This is something that I want to emphasize on. Here you can see the statements in the recent UEG and ESNM consensus on functional dyspepsia published in UEG journal this year. These are the statements and their endorsement regarding therapy. And surprisingly or not, you can see that most of these statements are not endorsed. For example, there is no endorsement for phytotherapy, for tricyclic antidepressants, for rifaximin, for Iberogast, for rifaximin, for hypnotherapy, for psychotherapy in patients with functional dyspepsia. The only therapies that are endorsed by UEG and ESNM in patients with functional dyspepsia are PPI therapy and eradication therapy. Even the prokinetics are not endorsed. And that's interesting, and it shows as a conclusion how complex is functional dyspepsia and how little knowledge do we have about this disorder. So probably in the future, we will have better therapies or better combination of therapies for this disease, because now we can rely just on PPIs and eradication therapy based on the recent guideline. And that's why, as a dessert, I've included the future directions slide, because we as GI Society, as international friends working in gastroenterology, have to think what we can do in order to have better management for our functional dyspepsia patients. We need an improved understanding of the disease mechanisms, definitely, and this will lead to improved diagnostic tests and potentially new therapeutic targets. We need new therapeutic targets. Functional dyspepsia most of the time overlaps with other functional GI disorders, but it's interesting that it overlaps with non-celiac wheat sensitivity, and both disorders might have duodenal eosinophilia. So wheat-free diets or even low FODMAP diets are something that we can discuss in the future in these patients. It's interesting to see what will be the effect of potassium competitive acid blockers in functional dyspepsia as the new kids on the block when we speak about acid reduction therapy. Also, it's interesting to combine the blockage of histamine 1 receptors and histamine 2 receptors to see what will be the effect in patients with functional dyspepsia. Interesting will be the studies to see what will be the effect of locally delivered budesonide targeting increased eosinophils in patients with functional dyspepsia. It's still under investigation. We definitely need novel drugs that suppress gastrointestinal eosinophils, and it's interesting to see what will be the effect of ghrelin agonists and HT4 agonists in functional dyspepsia patients. So as a conclusion and take-home messages, functional dyspepsia is really frequent, but still it's underdiagnosed. Future strategy should be to develop novel drugs and repurpose the existing therapies to target promising new mucosal disease targets. It's important to think about the modulation of relevant microbiome alterations in the stomach or small intestine, and the rise in understanding of the pathophysiology of functional dyspepsia is quite exciting and likely to usher the emergence of truly disease-modifying therapy. So thank you so much, and I'll be happy to stay in touch with you.